Hello, everybody. Today I'm going to talk about a very common injury that presents to the emergency room and affects everyone from children to the very elderly, distal radius fractures. As always, I don't make any money from this. This is done purely for education and for fun. All of these images were taken from publicly available websites on the internet, and I chose them because I thought that they illustrated the point that I was going to make. I'm not going to talk about distal radius fractures from an orthopedic surgeon's perspective because the way we see things is very different than the way an emergency room physician might see things, and we have a little bit of a different perspective. So I could spend an hour talking about the various nuances of treating them, but really the point of this talk is to appeal to and teach and educate as large and as broad a group of people as possible. A lot of the time, orthopedic surgeons don't even get involved in this stage, and these are evaluated, triaged, and treated entirely by the emergency room staff, and then they follow up in the office. So the goal of today is to sort of teach you about these injuries and how to prevent problems, how to reduce them properly, and a little bit about what happens afterwards. So basically, the first thing we're going to do is just to look at the basics of wrist x-rays. There's a couple of views that are important, and the most basic thing is to know what the bones are, right? So the carpus is this part of the wrist. Technically, the wrist joint is this, but some people can also refer to the wrist as any one of the joints between the carpal bones. The distal radius is, of course, the bone right here. This is a little bit of a oblique view, so you can actually see the surface of the distal radius. It has volar and dorsal projections, and then the distal ulna. Of course, distal means that they are the furthest away from the core. So in any long bone, you have a proximal part, a middle part, and a distal part, and the proximal end is the one that's closest to your body, and the distal end is the furthest away from your body. These are the metacarpal bones, and then you can't really see them on this x-ray, but the phalanges are the finger bones, and we're not going to be talking about them today. So here is a little bit of a better view. You can see the distal radius kind of flat on one line, and you can see the joint pretty well. Actually, I think this one might have a little bit of a radial styloid fracture now that I look at it, but I used it mostly to illustrate the normal relationship between the bones. So when we look at distal radius fractures, and the goal of really any fracture treatment is to restore the joint and to restore the bone to as close to normal as it could possibly be. Now, with some bones, they can take a lot of leeway. They can be crooked. They don't even have to be in the same neighborhood sometimes to heal. And some bones and some joints are much more picky and don't do very well unless you put them back together perfectly. I would say, if you asked me, the distal radius is kind of in between, but it's a very forgiving joint for the most part, which is why in many people these can be treated non-operatively and can have quite good results. But basically, the parts of the distal radius are the styloid, which is right here. That's the projection. And then the ulnar styloid is sort of the comparable piece of bone here. The distal radial ulnar joint, or the DRUJ, which is actually really important in restoration of function, particularly pronation and supination, which is rotation of your hand when you hold your hand palm upwards. That's the distal radial ulnar joint, and the forearm that's kind of responsible for that, and that's really important, particularly this portion here called the lunate facet, so-called because it articulates with the lunate, which is right here. Not really going to go into the details of that, just telling you what the parts are. And then counting the bones, because of course, I'm going to talk about the distal radius, but, we could talk about the carpus a little bit. And if you want an easy way, an easy mnemonic to memorize the carpal bones, here, the scaphoid, which is right here, has a little N, and I think that's because it is also called the navicular of the hand. Most people that I know do not use it. They just call it the scaphoid bone. So there is a mnemonic, as I said, and it starts from the thumb side, and the mnemonic goes like this: so long to pinky, here comes the thumb. Okay, so scaphoid, long, lunate, to triquetrum, pinky, pisiform, and then here comes the thumb. So here for H, hamate, C comes capitate, and then the two other T-bones. So there's the triquetrum here, and then there's the trapezoid and the trapezium, the thumb, because if you're going toward the thumb. So again, so long to pinky, here comes the thumb. So that's a nice little easy mnemonic for medical students and also orthopedic residents. So that's really the AP X-ray. And the lateral X-ray is a little bit more interesting. And I'm going to go back to these a little bit to point out some physiologic nuances between these two, because they are both normal, relatively normal. I mean, this one has a little fracture, but the morphology of the joint is normal. And if you notice here on this X-ray, the distal radius is a little bit higher. It's technically more distal, so depending on how you want to say it, higher or lower. But if you look at the joint, we call it, it's more distal than the ulna. It's a little bit higher in terms of this ledge right here, and that's generally true for most people. It's about 2 millimeters higher or so, and that's pretty normal, but that can vary. And so, for example, going back to this one, this is another fairly normal looking joint, and you see these are, I mean, granted, this is not the greatest projection, but you can see that the distal radius is more of in line with the distal ulna. Now, that could be completely normal. You'd have to take a picture of the other side to see, or it could be a sequela from a previous injury. But it's important because when you're restoring distal radius fractures to their normal length and alignment, you talk about length, and it's that relationship that you talk about, the relationship of the distal radius to the distal ulna, and I'll talk about that in a minute. Now, going to the lateral X-ray, and this is, when people show up in my office and they say, oh, did they get X-rays? Well, yeah, they did, but this is not really a good lateral because you cannot really see the joint. This is more of an oblique view, and this is what happens if you just put, when you're taking the X-ray, you put the wrist just flat on the ground. But in reality, the radius has a tilt to it in many planes, and this is really more of the X-ray that we are looking for. So now you can see the wrist joint pretty well, and you can see a lot over here. So first of all, you see the distal radius, and the distal radius, the radial shaft starts right here, and it's kind of hard to figure out where the radius and the ulna is, and the best way to tell is sort of to find the ulna here, and you can see that's the smaller bone. There's a projection of the ulna, and you kind of follow it down, and it's also slightly posterior on most of these X-rays. So this is the ulna, this is the ulna, and here you can see the distal ulna, and then right there, and then the distal radius is the rest. So here we're going up to the distal radius. That is the dorsal lip, so the thumb is over here, so this is volar, that's the palmar side, and that's the back side or the dorsal side. So this is the dorsal lip, and then you have the volar lip, which is right here, and you see that the dorsal lip is higher than the volar lip, and that is called the volar tilt, and that's really important when you're treating distal radius fractures, both initially and whatever your final treatment will be, because you want to try and restore as much of this original tilt as possible. Now, here are the measurements that we look at, and in orthopedics, we like rules, we like numbers, so we have this rule called 11, 11, and 22. So the 11, the first 11 is the radial height. So the tip of the radial styloid to the bottom part here of the distal radius, that is typically around 11 millimeters, and these are just the parameters that we use when we restore distal radius fractures to their normal alignment. This is what we're trying to recreate as much as possible. So that is the radial height. The radial, the volar tilt, I'm going to go to the next picture for a second here. So now the palmar side is right here on this picture. The dorsal side is here. So you see the dorsal lip is higher than the volar lip, and that angle is 11 degrees tilted volar. So it's tilted toward the palm. So that's the other 11. And then the 22, now going back to the other side here, the 22 is the radial inclination. So that is the angle at which the joint kind of goes if you look at it from, if we were to look at the joint kind of head on. Now, this technically is the amount of degrees you are supposed to move the forearm if you really want to get the perfect lateral, because you have to make up for that inclination. Otherwise, you're going to see a view that looks like this because it will overlap. So, so here is, again, just another representation of the 11, 11, and 22. So radial inclination, radial height or shortening, or the volar tilt. Now, this is a very typical distal radius fractures, and you'll notice a couple of things. If you judge it in the setting of those parameters, you will notice that the distal radius is short. So you see the ulna here, the distal radius is here. This is the joint surface. It belonged up here in most people, and you can see that it's down here. So there is a shortening of this bone in relationship to the ulna. Very often you will also see a scapholunate widening along with these fractures. That does not necessarily mean that you have an injury to this scapholunate ligament, and it's something that you kind of determine later on, but that's not something to worry about in the acute setting. And on the lateral x-ray, you can see here that the thumb is over here, so this is the volar side, that's the palmar side, and this is the dorsal side, and you can see that the tilt is now backwards. So the volar lip, which is right here, is now higher than the dorsal lip, so the radius is tilted dorsally, it's tilted backward, and that's what creates the so-called dinner fork deformity that people talk about with your very stereotypical distal radius fractures. And when people talk about the Colles fracture, that is what they mean, that dorsally angulated distal radius fracture. So here is another representation of what happens in distal radius fractures and the parameters we look for. So this is showing you now that instead of volar tilt, you have a dorsal tilt because the joint points now backwards instead of forward here, palmarly, like it's supposed to. You see the shortening here, the relationship of the distal radius and the distal ulna has changed. And why is that important? Well, if you go back to the other view here, if you leave it like this, and of course bones can heal in whatever position you put them in with few exceptions. So if you left it like this, let's say a patient was in a really bad car accident and nobody noticed that their wrist was swollen because they've been intubated for 2 weeks or they've been in a coma or something was going on, and people don't do thorough exams and they don't notice, or something happens and the patient can't tell you what happened, and let's say this wrist is allowed to heal that way. Well, what are the sequelae of that? A lot of that depends on the patient's age, and I will not go into that, but one of the things that can happen as a result of shortening is that the ulna kind of impacts itself into the carpal bones here. So you can imagine how this could lead to problems because these two bones are not supposed to touch, and you can go on to have arthritis problems. Also, you'll notice here that the distal radio-ulnar joint does not look very congruent, so they might have problems with pronation and supination, mostly supination, since pronation is much easier to achieve than pronation, which is turning your palm upwards. But again, how much somebody can take in terms of deformity and changes radiographically, you'd be surprised in many older people, and their wrists heal exactly like this, and they don't have much dysfunction. They're generally able to do all the things that they want to do, but I'm not going to get into that. This is kind of just an aside. So these are the things that we look for. And here is a good picture of something I'm going to talk about shortly called carpal alignment, or in the case of distal radius fractures, carpal malalignment. So the point of this is you want on the lateral view your capitate here, which is outlined in blue, and your lunate, which is outlined in red. And the reason it's called a lunate because it looks like a little moon. So luna means moon. And the distal radius, and you notice here the volar lip is here, the dorsal lip is here, a little bit slightly higher. But the point is that all these bones are supposed to line up. And in a distal radius fracture, that relationship can change. So if you look again here, this may look like it's carpally malaligned, but in reality this is normal. When you evaluate carpal alignment, really the way you're supposed to do it is not just to draw one line, but two. And one line is supposed to go up the shaft of the radius, and the other line is supposed to go through the capitate and the lunate. And the two lines are supposed to be intersecting. I mean, if they're the same, that's great, like they are here, but technically they are supposed to intersect within the carpus. So if you draw these two lines and they cross somewhere here, then you're good. Your carpal alignment is good, and that is what's happening here. So if, again, it's kind of hard to tell, but if you draw a line toward the proximal part of the distal radius, would kind of pass through the middle of the distal radius, and it would go like this, and then you draw a line down the capitate, which is right here, and down the lunate, which is right here, and your line is kind of crossing like this. So you can imagine these two lines would intersect somewhere in this region. So it's intersecting within the carpus, so your alignment is fine. And the two predictors of how somebody will do, other than the distal radial ulnar joint, are radial shortening, which I just talked about, and carpal malalignment. So if you look again at the distal radius fracture here, we've got shortening, which can cause ulnar impaction, and we have carpal malalignment, because now you're looking at what happens if you draw a line down the distal radial shaft. Now you're not drawing a line through here, through the joint. This is just through the shaft, and you continue that line wherever it goes. So that line goes over here. Now, what happens if you draw a line through the capitate and the lunate? It's somewhere over here. They will not cross within the carpus. They might not cross at all, in which case you have complete malalignment, because there's really no relationship anymore between the carpus and the radius, and that is carpal malalignment. So whatever you do, whether it's with casting or with surgery, you try and restore those two parameters. So what you're trying to do, even in the emergency room, even in your initial treatment and management of this, you are trying to offset these two things that have happened to the patient. You're trying to restore the length, and you're trying to restore the alignment. Now, that's your initial management. Whether that stays that way is very dependent on many factors, and again, I'm not going to go into it, but whether you try and do this with a cast or a splint. So for example here, you can see that the radius is short, and it's very difficult to see what's going on here, but it looks like they've restored a little bit of the length, at least to neutral. Now over here, you see again, this is a much better picture of carpal malalignment, because you see the remainder of the radius here, and if you imagine drawing that line here, and then you see the capitate and the lunate and drawing that line there, those lines don't even intersect. So the reduction maneuver kind of brings those two closer together, and then here, I know it's blurry, but you can sort of imagine that if you drew these lines now, they may have a chance of intersecting within the carpus. And if you manage to keep it this way, if you restore length and alignment, and you think that it is capable of not falling back to where it was and staying like that, staying normal in the cast, then a cast or a splint is perfect management for any distal radius fracture for the most part. But what happens over time is that once the swelling goes down, because you're putting these on acutely when the wrist is quite swollen, once the swelling goes down, the wrist kind of starts to wiggle within the splint, and then the bone falls back to where it came from. So if they wait too long to go see the orthopedist, by the time they get there, their wrist could look exactly the same, only now it has a splint on it. Now that may not be able to be prevented, but it's just something for us as orthopedic surgeons to watch out for. So if you can't keep this in the cast, how do you keep it together? You keep it with surgery. So this is a very severe distal radius fracture, which came along with a distal ulna fracture as well. You can see it here. That's supposed to be up there. And you see carpal malalignment at its sort of worst. So you see the line here and then the line here, and they're definitely not even in the same place. So I'm assuming that this was put back to at least a provisional reduction in a cast or a splint, and then this person was indicated for surgery, and you see here now the length has been restored. The distal radius is once again higher than the ulna. The ulna is pinned here, and then not an excellent lateral here, and it's a little bit obscured here by the plates and the pin, but you can tell now that the carpus is back where it belongs. It's no longer hanging out there in the back of the wrist. So those are our goals. And why reduce this at all? Okay, so there was a study that talked about just leaving these where they are, and because they were all going to get surgery anyway. Well, there's two problems with that. Number one, the patient may not want surgery. Number two, the patient may not need surgery if you reduce them properly and get it to stay, especially, for example, in the elderly, you get it to look at least somewhat reasonable, maybe not perfect, but reasonable. You can save the patient an operation. But if you leave this alone and you have the orthopedic surgeon see it, and let's say something happens, the patient doesn't show up for, I don't know, 4 days, 5 days, there is no way in heck you are ever going to be able to reduce that in the office. You're going to have to basically force the patient to have a surgery that may not have been necessary if someone had just reduced it correctly in the first place. There's another problem with this, and the other problem has to do with the carpal tunnel. So the median nerve, which we hear about in terms of its relationship to the carpal tunnel, and carpal tunnel syndrome is compression at the volar aspect of the wrist. Well, the carpal tunnel sits right here. So if you leave this wrist malreduced, a lot of the time you can develop carpal tunnel syndrome, and acute carpal tunnel syndrome becomes an emergency. So for the ER physicians listening, sometimes patients will come in with this and they will complain of numbness or tingling in the median nerve distribution, which is on the thumb side, particularly the first 3 digits, so the thumb, the index, and the long finger, and that's the innervation of the median nerve. And so they're going to complain of numbness and tingling, but once you reduce it, it will go away because the pressure on that carpal tunnel is relieved. And this can happen really with any distal radius fracture, but particularly in these very displaced ones, you have to really educate your patients about carpal tunnel syndrome, because these symptoms may develop even if they are reduced and even after they go home. And in those cases, it becomes an emergency, because that is essentially a compartment syndrome of the carpal tunnel, because the swelling's got nowhere to go. It's going to compress the nerve, and if you don't catch it and don't treat it with an acute carpal tunnel release, you could cause a lot of problems. And now here's that picture of the carpal tunnel. You see the median nerve passing in here and here. It looks pretty angry and red, and this was just a picture of the carpal tunnel just based on non-fracture conditions. But you can imagine, if you think about what happens to this wrist when it's broken, this whole carpus goes backwards, so kind of as you're looking at it here, away from you, and that carpal tunnel gets put on stretch. It is the nerve kind of rubs up against this ligament, and it's got nowhere to go, and so it's easy to see how you can develop acute carpal tunnel syndrome from that. So now that we've done that, and we know now that we want to restore length and alignment, and do not underestimate the importance of the ER provider or the orthopedic resident in treating these. You guys can really make or break what happens to this patient. So reducing it properly and putting on a properly molded cast or splint. Most people use splints. You can do a cast in an acute setting, but most people don't really want to go through that, and they worry about swelling. So putting on a splint is fine. Just make sure that the principles that you use are the same as the ones that you use for casting. So I'm going to go through that, and I think this is probably the most important part of this talk. So as I said, you're trying to restore length and alignment, and so this is kind of a representation of that dinner fork deformity that the patient shows up with. And as I've spoken about before, you can see here the shortening, and you can see the carpal malalignment. So your goal is to get this back to normal. So how do you get this back to normal? Well, you obviously want to pull on it a little bit. You want to pull traction to relieve some of that shortening, and you want to get back where you want to get the carpus back where it belongs. So you want to push it this way. But there is a step that a lot of people forget. What a lot of people do is they just push this forward to try and reduce it. But where that can cause a problem is that there is not enough traction and not enough translation. And I'll show you what this means by showing you this slide right here from the AO. So this is a little bit more difficult to see, but basically the volar side, okay, the palm side is here. So here's the distal radius, and technically it when it's broken, it's kind of further back toward the dorsal side. But this is really just demonstrating the reduction maneuver of what the ideal thing is. And there's a step here that is always missed. It's missed by residents. It's missed by almost everybody who's not used to treating these. And if you miss this step, you run a much higher chance of not really reducing this properly. And that step is actually this one. It's kind of a combination of this one and this one, but mostly this one, and I'll show you what I mean. So the first thing you want to do is you want to, if you go back here, if you just start pushing on this, you're not going to move very far, because this is kind of fallen not just backwards but down. So you have to really unlock this by pulling traction and exaggerating the deformity. So you really, the first step is to make things worse. So you want to basically create the deformity that did this. So you want to pull this carpus even further back to unlock this so that you can then move it up and over. So that is what that first step is showing you. So you are actually exaggerating the deformity. So you are grabbing kind of at their forearm, or sort of like at the bottom of their wrist right here, volarly, so palmarly on the palm side, and then you are grabbing their hand. Usually you grab their whole hand with your hand, but particularly the thumb, because it's much easier to maneuver. And I'll show you a picture of that in a moment here. You grab it and then you pull it backwards. Then you pull traction in this direction, going this way, so to kind of unlock it. And then you, still holding traction because you're trying to get that shortening restored, then you translate. So before you flex down, so people know usually to exaggerate the deformity when they read the books, and they know to use the traction. But then after they do the traction, the next thing they do is just flex it. They flex the wrist forward, and that is where most people go wrong. There is one more step before you flex the wrist forward, and that is translation. So you don't flex it, you move it over directly in this line. So once you have it exaggerated, you pull that way, and then you push right on the dorsum of the metacarpals. You push it forward, and then you flex. So that is what actually moves this distal fragment over, instead of just keeping it in the same place shortened but then flexed. So that movement, that translation, is the most important part of achieving a good reduction. And if you are vigilant, you will actually feel it and sometimes even hear it as it moves, because this part scrapes on this part. Now, this is obviously very exaggerated. It's not going to tilt that much, but it will slide over like this. Then you flex it, and your goal is to try and now lock it volarly so that it doesn't slide back. But the translation is really, really important, and that is actually what you're supposed to do. This is another good picture I took off the internet, and this demonstrates the other part of how to do a good reduction. You need a 3-point mold. This is how you mold your cast as well, but you also need a 3-point stabilization when you do the reduction. Because if you're just using both of your hands, the elbow is free to kind of flop around, and it's going to stop you from doing what you want to do with the wrist. So you need a stable base. So this gentleman here, covered in plaster, probably means that he's an orthopedic resident, but could be an ER physician or an ER resident, or somebody else. So I'm not going to judge it. Generally, those of us who are covered in plaster, spend our lives covered in plaster, are orthopedic surgeons. But anyway, so this gentleman is doing exactly the right thing. So he's got his foot. Unfortunately, we've only got 2 hands, and so unless you have somebody helping to do this for you, a lot of the time you have to use your knee or your foot to kind of hold the elbow and keep it from flopping around, and you're holding that on the outside of the elbow. So on the lateral side. The arm that is on the volar aspect, so the palm aspect right below the wrist, that is what's keeping you stable and allowing you to move this portion. And then you see his hand here is on the metacarpals, and that is where it should be. It shouldn't be kind of at the same level as the other hand, because then you're just kind of working against yourself. You're pushing one way, but then your other hand is stopping you. So obviously it should be higher, but neither is it kind of further down, because then you don't have as much control over that fragment. That fragment is right here, kind of on the bottom of his hand. So you want to put your hand right on the dorsum of those metacarpals, and if he is following the rule that I showed you, his first move is to translate it kind of away from us as we are looking at the picture, and then to flex. So that's how you do it. Now, the patient can be like this. When you do this, the patient can also be hung in finger traps to help you with some of that shortening, but nothing will substitute for this reduction maneuver. You actually have to physically move the bone. And then hope that it doesn't really fall back while you're putting your cast and your splint on, because obviously you're not really holding this as you go. And the same way that you're doing this is how you mold your splint and your cast, and I'm going to show it to you as well. The mold that you eventually put is exactly like this. But for the molding purposes, you're not going to need a mold over here because the elbow is now immobilized and it's not going to do anything. The mold of the cast happens here with these 2 hands. So Here's just a picture of the person in finger traps, and this is how you can kind of get things done and put and kind of hold traction and sort of help with that shortening. Now, the reason for the thumb and the index finger being in the finger traps is because you want to pull sort of on the radial side, because that's where the distal radius is. So if you hang them by the pinky, you're not going to do very much for the shortening that's occurring over here. So you want to hang them by either the thumb and the index finger, or by the index finger and the long finger. One of those two is fine. I personally find it easier to hang them by the index and the long fingers because it frees the thumb up so that I can move it to get my cast stuff around it, but you can do it however you want. And there's a little bit of specifics to the cast and how you place it and how you arrange it, which I'm going to talk about in a few minutes. But the most important part is when you hang them, typically you've done a hematoma block at the dorsum of the hand, so they're going to be complaining of finger pain. That's the worst pain. They're not really going to be complaining of much wrist pain, and then basically you just tell them that, unfortunately you can't really numb the fingers, but the pain will go away once you're done with the cast. So, and you can also hang weights from the forearm as long as you're far enough off the ground. So you can hang a very large stockinette and you can like create a little loop and then hang your weights from that to sort of help you along with gravity to help you maintain your length. And then you sort of maneuver the casting material around this as it hangs. Now, the one thing you have to remember before you hang them in the finger traps is to put the stockinette on, because if you don't put the stockinette on, you can't put it on anymore. So I've seen people run into issues when they do the hanging thing, do the reduction maneuver, and then they suddenly realize, oops, I can't put the stockinette on because they're already hanging, and they have to start all over again. So put the stockinette on before you start doing anything else. Okay, now here is what happens when people flex the wrist and do their cast. So there's a couple of things wrong with this cast. Number one, it's a little too short. So it's supposed to be as long as possible and still allow elbow flexion. Now this looks like it's like fairly okay, but I would prefer mine a little bit longer. The other part is that the wrist is very, very flexed. So I would avoid doing something like this because first of all, you cannot flex your fingers very well. You cannot make a fist when your wrist is in flexion. So that goes for putting on external fixators too. For any orthopedic residents that are listening, you want to put the wrist in as much of a neutral position as possible. So this is when people do this, usually that means that they have not done that translation step. Because if you've done that translation step and you've moved that fragment over, you do not need to flex the wrist that much to lock it. And that way the patient can actually move their fingers. So try this yourself. If you flex your wrist, try and make a fist. It's really hard. Now try and extend your wrist and you see how much easier it is to make a fist. And that's why, that's how the tendons are arranged that way, so that and they call it actually has a name. The position of function is slight wrist extension, so that you can form a fist. So your cast should not look like this for that reason, and then for another reason is because you're putting pressure on the carpal tunnel. So if you put your casts in extreme flexion, you can give somebody carpal tunnel syndrome. So just like with the distal radius fracture kind of moving backwards and causing pressure, you can also cause pressure of the carpal tunnel by moving the wrist too far forward. Now, about the molding of the wrist, we look back at this young man and what he's doing, and you want to mold the wrist the same way that you reduced it, because as I talked about, by the time the patient shows up in the office, a good mold can save that bone from falling backwards. So your first mold should be over the metacarpals, over the metacarpal bodies, and your other mold should be right kind of below the wrist. So one of the other issues here with this cast is that it's not very well molded. So a good cast, at least in the shaft part, should look like a little C. So it should have a mold from your hand that kind of goes like this, as I'm outlining here with my mouse. Now, where a lot of people go wrong, and I actually searched the internet for a well-molded cast, and I am ashamed to say I could not find it. This is the closest thing that I could find. So you see here, they tried to do the mold, but they're sort of fighting against themselves, because you see where that C is. You see where they put their hand to mold it, and they are fighting themselves because they are pushing from this side and they are molding on this side. So there's nothing really making that alignment kind of stay because you're sort of forcing it to be in neutral. Now but the wrist is actually in pretty good position. The wrist is in neutral. It's not overflexed. Now the way this cast could be better is that this mold should be a little bit higher, right at the metacarpals, because you want to kind of increase your little force on the carpus so that you can push that fragment which travels with the carpus. And the other part is that the C needs to move over here. So your hand needs to be just a little bit lower. It cannot be at the same level as your other hand when you're molding this cast, okay? In terms of what else about the cast or the splint, now in terms of length, now this is, I think, is a very good length. It's as low as possible. It's well protected here with stockinette, and the patient can bend their elbow. If you're doing a splint, you're doing a sugar tongue, so the elbow will be immobilized. But if you're doing a cast, this is perfectly fine. The thumb does not need to be immobilized unless they have a scaphoid fracture. So you cut out a really nice deep hole for the thumb, and you try not to leave any sharp corners here. Now, the other part of this is actually illustrated on the picture here, and that is about the metacarpals. Now, the metacarpals are in a cascade. They are not even. So a lot of the problems that I see when I have patients come see me in the office with splints and even casts sometimes is that whoever puts the cast on will first of all, they will not leave the metacarpals free to move. So you can see this right here, the index metacarpal, the patient will not be able to make a fist. So they will not be able to do finger exercises that you want them to do to avoid stiffness. So you always want to tell them, I want you to move your fingers as much as possible, because it's very, very easy to develop a claw hand from something like this, because the patient are afraid, they're in pain, they don't want to move. So you want to encourage them to move their fingers and their thumb as much as possible. Now, this is not a distal radius cast. This looks like a scaphoid fracture cast, so it's short. But I want to illustrate specifically, if you want to do a good cast for a distal radius, you do not need to go this high, that you need to leave all the knuckles free so that the patient can flex them down. Particularly in the palm, you kind of want to go at the palmar crease. You do not want to go all the way up to the fingers, because then they won't be able to make a fist. And what this cast is showing that's done well is that it is not straight this way. It is actually in line with the cascade of the metacarpals. So a lot of the time people will put on straight and then their pinky cannot bend. So you want to make sure that when you're putting your web roll and you're putting your cast material or your splint material or your plaster, you want to really be cognizant. And it's okay to make mistakes. So if you do something like this and you're like, oh my gosh, I think I immobilized the metacarpal heads too much, I need to do a little bit less, then you can always take a little cast saw and cut out a little wedge, and no big deal, no harm done. You don't need to replace the cast. Here's another picture. So this is actually showing a really good picture here of how the pinky is free to move. The volar part of the cast is at the distal palmar crease. The fracture is somewhere around here, so there's more than enough immobilization, and the fingers are free to move. The thumb has a really good cutout to it, and it's not impinged. It's well padded. Over here by the thumb is where a lot of people tend to have skin breakdown from sharp corners. Over here as well, so watch these very, very carefully, and also over here where they bend their elbow. So watch those areas in particularly very carefully when you are making your casts. Now, that's for your standard, Colley's fracture, the dorsally displaced fracture. There is another fracture that's a little bit more rare, but it's important to understand because it is treated differently in the emergency setting, and that is called the Smith fracture, or the volar Barton, as orthopedic surgeons call it. And so here it is, and you can see, just like in the dorsal fracture, there's some shortening, but there's a little bit of a difference here. And if you look at the distal radius, you kind of see that the carpus isn't really back in the back of the hand. It almost looks like it's a little forward, and it looks like it's traveling with this volar lip, and that's exactly what's happening. So instead of your standard distal radius, which kind of goes backwards, this is sort of a fracture subluxation where the whole carpus travels forward. Now, it's still carpally malaligned, because here's the end of the distal radius. You draw a line here, and you draw a line here. They don't intersect at all. So this is really kind of the opposite of the dorsally displaced fracture. Here is another picture of it, and here you can really see how it's different. So instead of being in the back here, the carpus is in the front. Now, why is this important? Number one, these are associated with carpal tunnel syndrome. Number two, the reduction maneuver is exactly the opposite of the other one. So if you try and push on the metacarpals dorsally forward, you're going to make things worse. So what you need to do is sort of think about, what do I need to do to get this carpus back where it belongs? So your mold and your reduction is going to be basically the mirror image. So instead of your palm being here on the volar aspect and your other hand being here, you are going to have your palm be here and the other hand be here and push it that way. Now, caveat about these are pretty much always 100% of the time they are operative, because unlike the dorsal distal radius fracture, there is really no cast or splint that can prevent this from moving back in this position. So your goal here is to kind of restore a little bit of the natural alignment, kind of take a little bit of pressure off that carpal tunnel, but this is a little bit of a different animal. This should be followed very, very closely, and this should see somebody in the office sooner rather than later, whereas the other type of distal radius fracture can wait a little bit longer. So that's really the distal radius fractures in isolation. Now, the other important part, and that I'll briefly talk about, is associated injuries. So when you see these, you have to be careful, because you really want to also take x-rays of the forearm, because a lot of the time you will be focusing on the obvious deformity and miss something higher. Now, you're probably not going to miss something like this. This is a segmental radius, so there's a distal radius here. There are obviously other fractures here, so you would notice that there was a problem, and then that would obviously prompt you to take pictures of the forearm and the elbow and all that such. But a lot of the time you can have a distal radius fracture that's associated with other injuries that may not be immediately visible. So this is a little bit different than a distal radius fracture, but this is called an Essex Lopresti injury, and that's basically a fracture of the radial head, which is up at the elbow, a disruption of the interosseous membrane, and a subluxation of the DRUJ. So typically it's not really associated with a fracture, but you have an issue at the wrist that's fairly clear. The patient has wrist pain, and then you're kind of tempted to just take your wrist x-rays and kind of send the patient out. But for every distal radius fracture, you really should have a forearm x-ray so that you can at least pick up on some of these potential associated problems. This is another picture of what happens, and so this is a really a much more a much less localized injury, and so and the entire interosseous membrane is disrupted, which you will not be able to see on an x-ray. So this is just something that you infer from the presence of these two injuries, and these are treated somewhat differently than your run-of-the-mill wrist injuries. Distal radius fractures are also often associated with injuries or fractures of the carpus, so it's very tempting to focus on this. So obvious distal radius fracture, and you kind of want to get it reduced, but you can miss other injuries such as this scaphoid fracture right here. So you always want to kind of be cognizant and be aware. Most of the time the radiologists will kind of pick up the injuries for you, but sometimes they are missed. So, do your usual so long to pinky, here comes the thumb, and take a look at the bones and make sure there isn't anything obvious. And the last thing I'm going to talk about is the open distal radius fracture. Now, when people think about open distal radius fractures, they think it's going to be right where the distal radius is, because that's where the broken part is, right? Well, in these cases, it is actually ulnar where the wound is. So this is, you can imagine this would be a fairly obvious injury, but sometimes they're very subtle, especially in the elderly. Volar, so meaning palmar, and ulnar is really where you want to look. So it may be as little as a poke hole, and in the grand scheme of things, it doesn't much matter, except that you probably should call orthopedics right away. And even though these don't need to be washed out on an emergency basis, they can wait 24 hours. That research work has been done, but these are probably not ones that you want to send home. At the very least, talk to your orthopedic surgeon on call and make sure they don't want to do anything else with it. And this is really what it looks like. So this is your volar ulnar wound. But again, these do not need to be that obvious. It can just be a little tiny bleeding poke hole. So do not be fooled in the sense of, well, it's a distal radius fracture, so it's not really an open fracture. This is absolutely an open fracture. And that's pretty much it. If you guys have any questions, feel free to visit my Twitter account. The link is in my bio. And thank you very much for listening.